Okay, well, I know we have a jam-packed session, so I am going to get started. Welcome everyone to today's session on cannabis use in perinatal period, taking care of the emotional and spiritual. Today, we are really lucky to have three lovely ladies joining us. We have Lucy Barney, who's our cultural advisor, patient experience and Indigenous lead, Jody Youb, harm reduction educator, and Tina Revai, clinical nurse specialist, harm reduction substance use. Before we actually begin, we are fortunate to also have Lucy Barney start us off in a wonderful way with an opening prayer. So Lucy, I will pass it over to you.
Thank you, Gemma. Hi, everyone. My name is Lucy Barney. I'm from the Tit Nation. As Gemma said, I'm the cultural advisor, patient experience in the nursing department at FNHA, and my other position is with Perinatal Services as Indigenous Lead. I want to thank you all for accepting the invitation to come and learn and share with us and with each other as we talk about women, cannabis, and harm reduction. It's an important topic. Women are our life givers. They're considered sacred, having the gift to give life. However, our lives have been interrupted. So we ask the Creator today for your open heart and your open minds so that we can learn how we can care for our women and others who become parents. We're looking today at the emotional and spiritual aspects of cannabis, and sometimes our people turn to substances that aren't healthy for them and who are also searching for the strength within them to carry on with what it is that they need to do. I ask the Creator today to thank you for being here, for sharing you with us so that you can care for our women and families. I ask the Creator that you've had a nutritious meal today to nurture your body, mind, and spirit. I ask the Creator for thanks for sharing everyone in the circle as we share and learn together. I want to acknowledge everyone on the team today for sharing their expertise and ask that the Creator also bless them and to keep them and their families safe. All my relations. Thank you.
Thank you so much, Lucy, for opening our circle in a good way. So first of all, I just want to start off with our land acknowledgement. As part of the FNHA, the First Nations Health Authority family, we always start with expressing gratitude to the people of the lands where we live. So I invite others to do the same in the chat. We're going to have a little bit more of a fulsome introduction where each facilitator who is joining us in this conversation today will be talking about our own area where we reside and the peoples where we live, but I invite you to put in the chat where you live. Next slide, please. And in doing this work, I just really want to acknowledge and put my hands up to the greater team that has supported us along the way. We've had input from just a wonderful group of folks: Paula Tate, Ashley Simpson, Gemma Greenwood, Barb Webster, Cynthia Russell, Julie Rakowski, Twinkle Ruparel, Kate Hodgson, and Kirsten Ellingson as part of the First Nations Health Authority team. So thank you. Next slide, please. So in having this circle come together today, we have a couple of co-learning roles, and I think we would like to think we maybe hold, I'd like to think I hold a little bit of expertise to share today, but I really do see myself as a co-learner in this work. And so I would really hope that what we achieve today is situating ourselves in this work. I think that's really important, so we'll speak to that. And learning about the factors that influence safety for Indigenous families, in particular those that use cannabis, that's our conversation today, and really recognizing and strengthening safer relationship as we partner with families, all the ways to do that, and recognizing and identifying person goals, family goals, community goals, and strategies to bring in wise practices. And I'd like to set some intentions for this space. So Lucy really wisely called this a circle, and that's, I know this is a virtual world that we live in, but I do view this as a circle where we've all come together, and echo Lucy's words that I really appreciate that you've taken the time to be here. So I really hope that this is a safe space to explore how we partner with the families we serve. How do we support families in a good way? And in particular, I want to bring alive the teachings of Lucy in really conceptualizing these two webinars. Part one was last week, and this week is part two, and really putting along the aspects of the medicine wheel, which brings us to a true holistic perspective on caring for families, pregnant people, community. And in that space, what I see is cannabis use is not the focus. Cannabis use becomes the context. So when we really center those that we serve. I also would really hope that in part of that safety that you feel free to ask questions. I think that's really important. So you can put your questions in the chat, or if you would prefer that your questions are private, please select Gemma's name and you can send directly to her, where she will read questions out. We'll have space at the end. If you click again, Gemma. Another really important piece here, I think, in this conversation is attending to your own safety as we have this discussion. This can be a topic that elicits a lot of emotions, as Lucy alluded to. This has been an area of disruption for folks, for many folks. So there can be pain in talking about what has led a family to a place of substance use. So we really want to hold that with gentleness today and with respect in having this conversation. It's really important that you take the time you need and take a break if you need to. And as well, you can reach out for help. As I said, some folks are monitoring the chat. The next slide, please. So as we said in our co-learning goals, I think it's important to really situate yourself in the work and answer the question of what brings you to working with folks at this sacred time. And so I invite others again to put in the chat what brings you to this work, maybe what brings you to this webinar today. And if it's okay, I'm going to share a little bit about myself and invite my facilitators to do the same. So I just want to say, again, greetings from myself. I'm Tina Revai, and I am a clinical nurse specialist with First Nations Health Authority. I am a second-generation settler of East and Southern European descent, and I want to humbly acknowledge and express great gratitude for the people and the ancestors in the place where I live, which is the unceded and traditional territory of the Nuu-Taunus. And particularly, I live on the lands of the Tashats and Upakasit peoples in what is known as Port Alberni. And in my role as a clinical nurse specialist for substance use and harm reduction, a lot of my work is around supporting nurses and programs and practice for those at FNHA. And what brings me to this place is 27 years ago, at the start of my career, I worked in mental health and substance use, and mostly in an urban setting where I was born. And my career and my family journey took me to working into community. And I've had really the absolute gift of being able to work in a few communities. And I've been in this area for the last 13 years where I've had an opportunity to work with the Nuu-Taunus nursing program, which has been a really huge mentorship to me in my learning. And just a lot of gratitude in working with families who are outside the community and who may be using substances. So I am really humbled to see how working to keep families together and support their healing journey, what a profound difference that makes. As a mother myself, I know the healing that this time can really mean to someone and change a story. So I'm very grateful to be here today and hopefully supporting this conversation and this work in a good way today. So thank you so much, and I invite Jody to share a little bit about herself as well.
Thank you, Tina. Hello, everyone, and thank you for joining us today. My name's Jody Youb, and I was born and raised in Fort Nelson. I'm a band member with Fort Nelson First Nation. I currently live, work, and play on the traditional ancestral territory of the Lheidli T'enneh here in Prince George. I graduated from the nursing program in 2009 and landed a job in community nursing. I knew in my heart that there was a need for this work, and I also had a need to better understand the healthcare system. I was hired as a community resource nurse with the pregnancy outreach program, and I worked there for about 10 years. The program's main focus was to support women, children, and families in a holistic and non-judgmental manner, and to focus on harm reduction. My focus was to provide a safe place for people and to build trust and relationship and community connections. Harm reduction has always been a big part of this work, and to meet each individual where they're at in their journey. In that 10 years, I took a year off to head back home to Fort Nelson, where I took part in the structuring of the Health and Wellness Center with Fort Nelson First Nation. And then in my previous position as a harm reduction educator for the Northern Region with First Nation Health Authority, I started about a year ago. And I just feel so lucky and grateful to be doing this work that we do, and to work with community members and healthcare providers. Thank you.
Thank you. My name's Lucy Barney. I am from the First Nation, which is Interior, Statlium. I became a nurse in 1997. I worked at the Canadian Diabetes Association, and during my nursing education, I learned that there were a lot of projects and articles that weren't holistic. And so I saw that as an opportunity to look at holistic health in my nursing education, and then was hired onto the Canadian Diabetes Association because a lot of the work I did in nursing was on diabetes and First Nation people. Because I have so many family members with diabetes, I've witnessed a lot of people becoming very ill with diabetes, not being diagnosed for decades before landing in the emergency department with a heart attack, not knowing that they've had diabetes for 10 to 20 years. I learned then that there were a lot of barriers in place for Indigenous people to access healthcare, no matter what disease or illness they were. So my purpose in life is to learn and share my knowledge with everyone on what it is that is important for Indigenous people and their health and well-being. And my main purpose as well is learning that it's our spirit, the strength of who we are as individuals, as families, and as communities that will bring us to that point of wellness. Thank you very much.
Thank you. Next slide, please. We're going to talk about trauma-informed care. So trauma-informed care is a framework for human service delivery. It's based on knowledge and understanding how trauma affects people's lives, their service needs, and their service usages. It includes safety, trust, empowerment, offering choices, collaboration, awareness of culture, and having the utmost respect. It is so important to have the knowledge and to understand how trauma affects people's lives. There's kind of two ways to look at it. So trauma-specific care includes qualified counseling and clinical treatment. And the second one is trauma-informed care. And this includes awareness and practical strategies. Trauma can be a single event, connected series of events, and can include chronic lasting stress. Trauma is underreported and underdiagnosed. We have pretty poor surveillance data from the frequency of violence, but in a one-time Stats Canada survey, half, so that means 50% of Canadian women over the age of 18 reported having experienced physical or sexual violence. And 76% of Canadian adults reported some form of trauma exposures in their lifetime, so a really large number. Traumatic events overwhelm the ordinary systems of care that gives people a sense of control, connection, and meaning. Some key elements of trauma-informed care include attending to a person's immediate needs. So when somebody's coming in into your place of work, identifying those immediate needs, and those could look different for each individual. Being transparent and consistent in interactions. So we all know how often staff turnover or things like that can happen, so just no consistency. So being aware of that. Thinking about and removing barriers to engagement, obtaining informed consent, really explaining what confidentiality is and limits to it. Trauma may be relevant in a few different ways. So the person may have a history of trauma, and we really need to remember that trauma is self-identified and occurs in a range of possible circumstances. It could be a history of abuse or experience of intergenerational trauma. Disclosure is not necessary, and we really must respect that. Regardless of disclosure, trauma-informed care recognizes that many people have experienced trauma and recommends a universal precaution amongst healthcare providers as best practice. Next slide, please. Harm reduction. So harm reduction is a public health approach that saves lives by minimizing harm and potential danger. It meets people where they're at with open arms, acceptance, and compassion. So never judgment or shame. And it recognizes that every life is valuable and that substance use and addiction can be complex and really challenging. So First Nation Health Authority's framework for action, when it was done, it has 4 action areas. So the first one is to prevent people who overdose from dying, to keep people safe when they're using substances, to create an accessible range of treatment options, and to support people on their healing journey. We use harm reduction. We all use it in our daily life. Some examples may include wearing a seatbelt while driving a car, carrying an naloxone kit to prevent an overdose, taking a prenatal vitamin during pregnancy. If a person is using cannabis, offering vitamin C or education on vitamins, as cannabis can deplete the body of vitamin C. Another way to incorporate harm reduction into your practice is to offer a healthy snack or a glass of water during a prenatal visit. So these are all just examples of harm reduction. Thank you. Next slide.
Hi, it's me, Lucy again. I'm here to share the braid theory that we're creating for harm reduction, but a little bit of background of how the braid theory came to me. When I was a nursing student and working at the Canadian Diabetes Association, their conference was coming up and they asked me to share why Indigenous people don't comply with their regime of eating from the 4 food groups, buying gym membership, taking their insulin, going to their diabetes educator to learn about their diabetes. And so I did that. I am a dancer. So the day before the conference, I was at a powwow and I was braiding my hair. And it just came to me suddenly that we braid our hair and it has 3 strands and each strand has a meaning. One strand means the mind, the other the body, and the third the spirit. And we're told when we braid our hair and we braid it as tight as we can, that all the negative will leave. We're also told that when we braid our hair, that we're taking care of ourselves. For so long, our Indigenous people haven't been able to take care of ourselves because of the outlawing of our culture, our beliefs, values, and our ceremonies, which weakened us. And then we were made to live other ways of life, which didn't really provide an environment where our people could thrive, continue to live, faced with a lot of racism, therefore turning to unhealthy behavior. When I asked at this Canadian Diabetes Association, I actually asked them, what do they see our people experiencing every day? And I told them to write anything down. I had these little stickies. We didn't have Post-it notes in them days. So I used these file folder tabs, and I cut them up, and I asked, there was about 150 of them. I had them on their tables. I said to write anything down that they want. And I said, you won't hurt my feelings. I live this 24/7. And so a lot of them wrote on the addictions, the alcohol, the drugs, the smoking, the low self-esteem. They wrote all of that stuff down. They wrote that we're overrepresented in diabetes. They wrote that we're overrepresented in teen pregnancy. What they left out was the fact that our people also have a spirit, and that was missing. So with that presentation that day, I brought these really long strips of material, and I asked each one of them to put their stickies on either the mind, body, and spirit. And I explained to each one of I talked to each one of their words and explained why. So I call this harm reduction braid, Understanding the Mind, Body, and Spirit in Indigenous Harm Reduction, a life interrupted, because our lives have been interrupted. And it doesn't matter what illness that our people are experiencing, it's the same thing under the mind. It's the same thing we need under the spirit. And when FNHA created the harm reduction model, they used the wolf, which represents relationships and care, the bear, strength and protection, the eagle, knowledge and wisdom. Next slide, please. And then when we start weaving or braiding, looking at whatever it is that our people are experiencing under the mind, body, and spirit, whether it's an addiction to cigarette smoking or to weed or gambling, that we weave, we understand that, because if we're diagnosed with HIV, TB, with an addiction, it's because of things that are affecting our mind. And when we're finally diagnosed with an illness, the barrier still exists for us, whatever is under our mind. Therefore, we need to start weaving, braiding the spirit back into our people, whatever that strength is, and whatever that person that is in front of you states it is, whether it's a religious church or spirituality or their own way of caring for themselves. Next slide, please. When you braid it all together, as I said at the beginning, we braid it really tight. Therefore, all the negativity leaves. We become very strong. When you have your braided hair, it is very difficult to break, as opposed to a single strand like the body or like the mind. Very difficult to break apart. It's important. I know that these words are difficult to see. We're working on the PowerPoint with a graphic designer. And next slide, please. So that was the building up to reconnecting the mind, body, and spirit in Indigenous harm reduction. So looking at the strengths of the eagle, the bear, and the wolf, the mind, body, and spirit, looking at prevention of the use of drugs, being non-judgmental, being compassionate. Sometimes our people are scared, and ask, why are they scared? You could help them out. They may not say they're scared, but they may be scared because of previous experience. They may be afraid of embracing change, but they are open when you ask them questions, when you give them the time. And when you look at the body, they may find things that will help them become stronger. Like keeping busy. My mother always said, when you're feeling down or you're thinking of going to do something, like go drink or something, she said, keep busy, you'll stay out of trouble. That was my mother's words always. And always, always keeping yourself safe, knowing your environment, asking the client, what is your environment like? Is it safe? Do you know who's there? that was one of my other mother's teachings, is always know your environment, whether it's safe, and always have an escape route, because she went to residential school. She never talked about residential school. She just tried to keep us safe. And so looking at the spirit, you know, building on their strength. Who is their family? Who do they decide who their family is? Is it their blood family, or is it their adopted family? Do they have this sense of belonging? And knowing of ceremonies. I've known a lot of people with addictions who know their ceremonies and why it is that they couldn't turn to them. You know, they may not have had the right support, or they were scared to turn to ceremony. I was at a powwow once, and they say no drugs or alcohol. And this one man who was under the influence of alcohol came into the powwow, and they kicked him out right away. And I went over to the security guy. I said, you know what? This guy may be the bravest he's ever been to come to the powwow. And they let him stay as long as he said he would behave. Next slide. So it is really important, you know, when your client is in front of you, to look at asking them, what are your strengths? What makes you strong? What makes you thrive? What will help you take the next step to being healthy? Weaving in the mind, body, and spirit. And when you do that, they become strong. They become self-determining, as it is with the FNHA way of being and being a part of this family. Thank you very much.
Next slide, please. Cultural safety and humility. So culturally safety is the act of providing safe and equitable health services to Indigenous people, where the relationship between client and service provider is built on a foundation of trust and respect and no judgment. It takes into account cultural practices and beliefs, and it meets every individual where they're at. So as healthcare providers, we do hold a lot of power in many different situations. Cultural humility involves humbly acknowledging oneself as a learner when it comes to understanding another's experience. I feel that it's our job to learn and seek the knowledge needed and to have the conversations needed to better understand cultural safety and humility. This means putting personal or systemic biases aside to develop respectful and trusting relationships. Decolonizing practice involves dismantling structures that perpetuate the status quo, addressing unbalanced power dynamics, surfacing settler biases and assumptions while honoring and valuing Indigenous knowledges and approaches. Healing is embedded in culture and tradition, and the more we understand these, the more we can build relationships and better understand what is needed. Next slide, please.
Hey everyone, yeah, I just want to really acknowledge what my co-facilitators have said around the importance of culture, both for myself as a settler in terms of acknowledging my humility in understanding experience, and also really having a clear commitment to understanding culture as being medicine for Indigenous healing, and as Lucy shared in the BRAID theory. So culture really is medicine, and that's a significant teaching in the communities that I've worked in and with ancestors and elders. And I just want to share for those who might be kind of a little bit sort of love a little bit of science, because these are referenced at the back, that science is only catching up with what ancestors and elders and knowledge keepers have shared all along the way. Culture is both a protective factor, so having a connection to one's experience of land, song, dance, ceremony, teachings, as Lucy said, actually reduce some factors in their health experience, but it's also a resilience factor. So what that means is when people may have experiences of, for example, racism in their childhood, or experiences of education that is lower, that in fact having that cultural connection actually buffers or reduces any negative impact. So it is a significant and important and sacred form of medicine. Next slide, please. So I just, I'm going to be diving into a tiny little bit in plain sight. And I really think this area can be heavy. This can be a bit of a heavy topic. So I just want to remind you to take care of yourself. We will be taking breaks, but please know you are encouraged to take care of your safety, and a reminder of an option to send a message to Gemma if you need to reach out for support or to ask a question. So this slide comes from page 27 of the In Plain Sight data report. And there's a couple of things that are really, I think, important to our conversation today. The two bars, the sort of rust color bar speaks to Indigenous folks' answers in terms of whether they feel safe or not with care. So an answer here particularly is not at all feeling safe. And the brown color bar is non-Indigenous folks. So right off just glancing at this chart, we can see that largely and consistently, Indigenous folks do not feel safe in terms of healthcare services at all in the same way as non-Indigenous folks. And that's really a call to bring change to service for all of us. Other thing that sort of I see in my mind when I think about our conversation today with cannabis use and parents is the second graph, or sort of the second bar there, which is the hospital social worker. This came up quite a bit in the report in Plain Sight, that interactions with social workers and MCFD representatives or delegated authorities were said multiple times by multiple respondents as something that folks and families are particularly fearful of when they're visiting hospitals or giving birth, due to concerns that children will be apprehended. And so this is a very real fear that many of the families we serve are experiencing. And so we do need to be aware of that and really support people in a good way and make change around this. So next slide, please. So when we reflect on the idea of safety and how that might impact, this is an activity for all of us. So when we think about safety and how that may impact the healthcare relationship and outcomes, I'm going to ask everyone here. So whether you can use the whiteboard, and Gemma will talk us through that, or put in the chat, but how does safety or lack of safety, how does that really impact the healthcare relationship, and what kind of outcomes result when people don't feel safe? Emma, do you want to add in there in terms of how to make the whiteboard work?
Yeah, absolutely. So if you'd like to use the whiteboard, along the top of your screen, you should see where it says View Options. If you click on that and then select Annotate, you'll get that little bar like what you see on the screen. And if you just click on text, it will give you like a little text box like what you're used to, or you may have seen using a PowerPoint presentation, and just go ahead and start typing in. It will, if you move away from it, it does stop you from typing. So just carry on typing without stopping. If this is a bit hard, then please feel free to use the chat box to add your answers or comments.
Oh, I love all the answers. And I love when technology works, because that's always the worry as a facilitator. Somehow the technology will not work. I think I'll start reading some of them out, but I really appreciate everyone's thoughtfulness in terms of thinking about how when care is not feeling safe and when there's a difference, what that means. So I'm seeing if feeling unsafe, one might isolate. If feeling unsafe, may or may not return to access care or support. Less likely to seek support. Not safe to share, so may not receive accurate treatment. Feeling unsafe makes it difficult to trust the healthcare provider is acting in your best interest. Yeah, that relationship may not feel safe sharing personal health information. So true. It's really sacred when folks share with what's going on for them. Might not share their real needs and therefore more trauma instead of healthcare. Unsafe environment, less likely to seek support, less trust, not access services. If providers or services are unsafe, people might not engage except for in extreme circumstances, that's true, and not fully engaging in full treatment and follow-up. So really, really great answers and thoughtful answers. Did I miss anything in the chat, Gemma, or is that?
No, everybody used the whiteboard, which is awesome.
Wow, what a great group.
Yeah.
We use the technology. Okay, next slide, please.
Okay, give me 1 second. Over to you.
Okay, and you know, a lot of the answers you gave are really consistent with findings in plain sight and really relevant to our topic today. In plain sight found a significant difference between Indigenous mothers, excuse me, accessing prenatal care compared with non-Indigenous folks. So we really see a difference. And again, I think that perceived lack of safety as well, the report talks about, also actually shows up in that there is a difference in the rate between Indigenous women leaving hospital against medical advice at a higher rate than non-Indigenous folks. So it exactly speaks to what was said in the previous slides, is people are not getting full spectrum and full care because they just don't feel safe. Next slide. Just want to take a moment to pause because I think these are real people and stories in those numbers and in that description. So just looking at this beautiful image from my colleague Jody and her community, I invite you to take a cleansing breath as we just take a break to just get some renewed energy and continuing this conversation in a good way. So a cleansing breath for me is a nice deep inhale. Focus on your exhale. Really lovely thing to do with clients and those we work with who might be open to that, is taking a cleansing breath and just grounding ourselves in our bodies again, the place of strength. So next slide. So I think this is a really important slide for understanding factors associated with perinatal substance use amongst pregnant people, period. And on the right side, you'll see the reasons or the factors that are associated with perinatal substance use for non-Indigenous women. Now, today we're talking about cannabis use. We're not talking about all perinatal substance use, but I think those factors really hold. And so those are the pieces that often will lead to substance use as a way of coping, as Lucy shared, when that's sometimes the tools you have at hand. It's really important on the left-hand side to talk about the factors that actually come before, the factors that actually lead folks during this time to have perhaps different rates of depression or different rates of trauma. And those all relate to colonization. So when we look at that, we see residential school experience, the 60s and 70s scoops, people being taken away from their families, the loss of Indigenous women and girls. So we recently on May 5th recognized missing and murdered Indigenous women and girls and two-spirited folks. Experience of Indian hospitals, forced sterilization, and as well, kind of circling back to why people might be afraid of working with social workers is disproportionate child removals. And so just to get a number on that, this 2016 census showed that First Nation, Inuit, and Métis children represented only 7.7% of all children under age 15 in Canada, but accounted for 52.2% of children in foster care. So there's a very real reason for folks to have the fears that they do, and a lot of work ahead for people like myself to make the system very different than it is today. So yeah, next slide, please. And I would just like to take a moment to pause as we talk about this very heavy information, but important information to understand why we are where we are and to make change. We have to say hello to things before we can move on and have growth. So for me, I'm taking this moment to pause, and this is a picture from my local community. This is a Nuu-chah-nulth whaling canoe, and the Nuu-chah-nulth people are recognized for their whaling, and their culture is really strongly identified with whaling. So I just take a moment to think of your own ancestors and the gifts and the strength that your people bring to all that have come before. And may they guide us today. Okay, so next slide. So when we're talking about some of these experiences, and we're really in many ways talking about stigma, and stigma is a part of structural violence, and I see racism as part of being part of structural violence. And it plays out for people in a couple of different ways. When we think about the interpersonal aspect, we think about what's going on inside of us. And we have the aspect of enacted stigma, which is the actual, just the stress of being treated unfairly. So that is something that comes up time and time again, as well as internalized stigma. So feelings of low self-esteem and shame that come because of the messages I've received. And anticipated stigma, so not accessing support in the same way because I don't think I'm going to get fair treatment. So then that leads me to not want to access. Then we can also think about how stigma plays out between myself and perhaps another care provider. How is language being used? Is it being used in a strength-based way? Is it being used to humanize me, or is it being used in terms of labels? My name might not be correct, said correctly. My nation may not be said correctly. Is someone not seeking to see who I am? As well, what are the questions like? So are the questions more policing questions? Am I subject to more questions because of my, maybe because of my, what I have a racialized identity? So we know that there can be some differences there. And so thinking through to that. The next slide, please. So when you think about care and the care that you deliver, and when we think about, again, those aspects of stigma and safety, what do you do to make care safer? And if you're someone on the call who maybe isn't a care provider but has had experiences with healthcare providers, what do you wish that was done differently to make care safer? So again, we're going to use that lovely annotate, which sounds like most people know how to use, but Gemma, I will let you speak to.
Great, thank you. Okay, just once again, it's over in the view options. So Carol, I see you couldn't get it to work. Let's see if this time it works. View options and then select annotate. But if not, sorry to call you out, Carol, feel free to use the chat again. And I'll make it a little bit harder. See if anyone can figure out how to change the color of your text. Not really, just adding the text is perfect.
I'll make it harder. Oh, and you can draw it out too.
Oh, I love it. People are finding the color. Yay. Once again, it's just under view options and then select annotate.
All good, Naomi. I'm really appreciating the circle that we're building here today to have this conversation. Oh, Carol's got the drawing going, but okay. I'm going to start reading some of them out, but that doesn't mean if you still have more to share, please add. I really hope that this conversation today will start to stimulate even more ideas to strengthen the great practice you already do. But I love what folks have written. So informed consent, introducing yourself, listening without interrupting, mental collaboration, listening, ask if they fully understand, and actually wait for a response. Healthcare providers, I can say I'm guilty of this. I've been doing this for over 27 years, and it's taken me a long time to really slow down and listen deeply. Having consultation with First Nations, yes, that's going to make big changes in how service and practice is done differently. Taking time to actively listen and create trusting relationships, taking time, building relationships. I love humble curiosity, trauma-informed, allow for silence and for thoughts. Such great suggestions. And I'm seeing in the chat as well, being patient, silence is okay. More training for racism and reverse racism. So thank you so much, everyone. Next slide. So in terms of really healing from that stigma relationship, the things that are so important there are, as described by many of you, is that connection. And in connection, when we really take the time to respectfully develop the relationship, we can really challenge stigmatizing beliefs with others, including our colleagues, is really important. We can improve coping skills, support empowerment, build social support, share a safe space to share personal stories. Connection includes culture, land, spiritual beliefs, as we shared earlier. Educational interventions to address stigma include targeting myths, lack of knowledge, that piece around, someone mentioned around addressing racism. And important for healthcare providers to really be reflective, to examine their own personal values, beliefs, biases. So we do have bias and we need to surface this. And I would just invite everyone on the call to think about their own practice environment and how do you take the time to build in your reflective practice? Who do you have to take the time to talk with about your practice and improving it? Okay, so next slide. Other activity. Oh, and this time we're going to do a poll. So here's a question as we start to get into more around the cases. Can a person who uses cannabis be a good parent? I invite everyone to give their answer. Ah, okay. So we've got a yes at 96% and 4% maybe. And for me, I will tell my own personal bias and is glad to hear that no one wrote no. I think that's a really important thing here today. And we can close that, Gemma. And I think if you click again, Yeah, I think it's really important when that was a little bit of a provocative question, because I think that it's important to unpack what good parenting means. And so bottom line, I think that question was, can a person be a good parent? Of course they can, because I think it's really about what is good parenting and what does that look like? And why do those words matter, right? And why, moving back and circling back to thinking about trauma-informed care, that we really are not there to judge someone, but we are there to support responsive parenting and to empower, as Lucy said. Next slide. So just a recap of some basic knowledge around child protection. During pregnancy, there is no duty to report for any substance use, and in part that's because that what we're talking about is that there isn't a child, from a legal perspective, there isn't a child yet. If someone is disclosing they have substance use, that's an opportunity to build relationship and to really center their goals, but there is no duty to report. So we don't have birth alerts. Birth alerts is a practice that used to have hospital staff alert child health care workers that a newborn may be at risk without informing expectant parents. So that we got rid of, I think, about 2 years ago. However, I do want to also make a pause for everyone to reflect on their community, because I am hearing that some communities members report that this is still kind of happening informally. So really thinking through, how do we advocate for the rights of our clients. And as well, once they're after a birth and you have a child, cannabis use alone or substance use alone is not an indication of child for involvement of child protection services. So it's really, is this parent, are they able to parent responsibly? Are they able to remain responsive? What are they doing to reduce harm in their environment? Those are really important questions to ask and work on together as you work through that piece. Okay, next slide. And this is a way of approaching clinical care in moments that matter, and it was shared with me by my colleague Paula Tate, who is an Indigenous wellness educator on the team that I'm on, and she shared this as part of her Indigenous leadership training. And these powerful questions will help us gain clarity while addressing the 4 quadrants of the medicine wheel, and they can be used by both the nurse or service provider when you're not feeling grounded, when you are in an area that maybe is new to you and you're not able to be fully present in the conversation to support that family or that person. And they can also be used for a parent. So if this might be some really good tools for the folks that you're working with. So I really invite you to keep these questions in mind as we go through some stories of care. Moving ahead. And by the way, we will make these slides.
Tina, we've lost your audio, Tina. I don't know if you can hear me. Oh no, she can't hear me because she's lost her audio. One second, everyone, as we try to get Tina. Jody, can you still hear us?
I can hear, yeah.
Great. I wonder if, do you want to carry on from where Tina left off?
Sure.
If that works, and I will try and get Tina back on.
That sounds great.
Okay.
So we're going to look at a case study here of Monica, who's 19 years old, and she has come into our community health center to access services, and she's brought in by her aunt, and she shares that she's 13 weeks pregnant. So what are we going to be curious about? And I invite anyone to share in the chat if they have any input or if they want to answer these questions as well and kind of walk through the case study with us. So one of my things would be, does Monica feel safe in her space? What kind of relationship does her and her aunt have? Is she comfortable sharing personal things with us? How is she feeling about her pregnancy and just feeling in general today? And what does support and connection look like for Monica? Is this a good time for Monica? Is she hungry? Could we offer her a snack, possibly something to drink? And would it be better to wait to either do the intake or the big spiel about what the program can offer? I know that in my previous job, mom came in to access services. Her worker called, said she was being difficult that morning, but she needed to access some food because she was out of food. And one of our things was that we gave out vouchers. So she came in, she wasn't in a good mood. She didn't want to do the intake. The intake takes about an hour. But then after completing half of it, realizing that this woman that was pregnant hadn't eaten for 2 days. So made her a really nice, healthy, good snack, sat and talked with her, made her tea. And the intake process was completely different after this mom had a chance to eat something. So just being really aware of all aspects. Another question is, how will you build connection? I think it's really important. You know, sometimes silence is key. So asking mom what her needs are and what that might look like for her. I'm not sure if anyone wants to join in the chat as well. Focus on the priorities for Monica and working with her at her pace. And we really want to ask open-ended questions. You know, what are you looking for today, Monica? What are your goals? What can we support you with? And then the next question is, what are some of Monica's strengths? So what is her connection with family or community? She might not have any family besides her aunt, but that doesn't mean she doesn't have really strong family community ties. Does she have any connection to her culture? What does she do for self-care? What does self-care look like for Monica? Does she have any goals that we can help support her to achieve? We also don't want to bombard her with too many questions right off the initial visit. We would want to show her things possibly like where the washroom is. We know that pregnant people have to use the washroom quite a bit more frequently. So it's really important to let her know that and just let her know that we're a safe place for her.
Can you hear me again?
We can hear you, Tina.
Oh, I'm so sorry.
No worries. I just went over the case study questions. I do believe we can go to the next slide, if we can, or the form. That's the form I was talking about there. So that was the intake form. Looks very clinical. So possibly, like I said, we don't want to bombard. We don't want to have Monica sitting across from our desk and check marking these. There's some really personal questions in here. Is she comfortable with her aunt answering these? If her aunt's sitting right there, we might not get the full picture. So possibly just sitting and having a discussion and seeing how much of this form we can get filled out, and then asking Monica to possibly come back.
Yeah, thank you so much for picking up for me there, team.
Welcome back. No worries, those things happen.
Yeah, internet, I don't know what happened there. Yeah, exactly. I think when we work through this together as a team, one of the things we really looked at is how much control do you have over your forms? And are your forms trauma informed? Can you make some changes to them? And like as Jody shared, can we support this person in filling it in, but also, you know, what these questions land on someone, right? We can see on the right-hand side there, midway down, you know, it says history of abuse or violence. These are deeply personal questions, and we're going to assume this is a situation where we don't have relationship yet. And sometimes thinking through programs that maybe invite people to connect have, maybe there's a reason she's connecting to get vitamins from us. Maybe we have the ability to do that, or maybe we have vouchers for foods. And so really checking in with your team about what's the minimum to get things going, because we don't have to answer all those questions. Going back to that sharing around the 4 quadrants, some things can wait and some things should wait. So really having that, thinking what is the minimum in order to support this person now. And I know we chit-chatted together about really having a good conversation pretty close to the front of the relationship around confidentiality and the limits to confidentiality. So as we shared, someone disclosing substance use is not a reason to report. But at some point, you know, we also need to share that when there is a child, if there's other children in the house and they're in unsafe circumstances, we have a duty to report. And by sharing that up front, we're being trauma informed, we're being transparent about what this relationship will look like. And in my experience, I think families really appreciate knowing that. Sometimes I think they will disclose things going on with them because they do want that supported they want that supported option to have a conversation with other folks, and that's a way of getting help. But it's really important we talk about confidentiality. Did I miss anything? My apologies, everyone.
No worries.
Okay, next slide, please.
So Monica shares that she and her partner stopped partying when she found out about her pregnancy. So we started to build some relationship with her. Kind of what are we curious about as a practitioner? How would you ask her? So again, you're welcome to put ideas in the chat box. For example, we could say, I hear that you and your partner made a change around your partying. How is that working for you both? What activities or hobbies are keeping you both busy? Because we know with substance use or addictions, you know, people stop using and then they're looking for other things to do. So supporting that. Do you have any connection to supports or activities in the community? For lots of people, this is a time for making new relationships or meeting other parents to be and strengthening connections with family and community.
Click again. So next she shares that she and her partner have cut back on smoking weed and she no longer drinks. And so when I hear that, I really think this is an opportunity for listening well and also really affirming what she has shared with us today. So as we talked about earlier, that when someone talks about what's really going on for them, that's an act of trust. So part of my job is to make sure I'm listening really well. And so I would want to sort of maybe feedback what I'm hearing. It sounds like making changes around weed and drinking are important to you. Again, how are those changes going? What's helped you with this? And does she feel she needs any more support or help with the changes she's made? Given some of what I learned last week with Dr. Carolyn Marchand is when folks are using cannabis and smoking together, that there's a layered effect and that it can really affect things like blood pressure. So I do become curious about that. Is she using other substances? But again, I have to be very respectful of the timing. Like, is this the time to ask? What is she disclosing? But if we get there, that might be something with her permission to give her some an opportunity for sharing our learning around that. So what does she, you know, if we think about that she might be smoking, does she smoke? Does she vape? Lots of folks are vaping now. Is she in an environment where others are smoking? Lots of families live together with lots of folks in the family. So what does she know about secondhand smoking and pregnancy health, and what is she doing to protect herself already? So often if we just ask the question, what are you doing to maybe reduce your own exposure to secondhand smoke? I think it's really important to hear what folks are already addressing and to affirm the changes that they've already made. And next, thank you.
So Monica has been having nausea and some vomiting. Her girlfriend has told her that smoking weed may help her. And she says, I don't know what to think. I don't want to hurt the baby. So we can reassure her that that's a great question. And it sounds like she's been experiencing nausea and vomiting. And it sounds like it's concerning for her. So we want to ask if she has access to healthy food and what her diet might look like. Let her know that smaller meals and snacking can also help get her daily recommended calories. And if she wants information on cannabis use during pregnancy, that we'd be happy to help her with that. But again, just making sure that now is the right time and place with Monica. And just letting her know that we'd be happy to discuss it with her and that we're available anytime. And we can also ask her what she's tried, possibly, what's working for her and what's really not working, what time of the day she feels her worst, and then go from there. Thank you. Next slide, please.
I just want to pause for a moment, seeing that we're over time. So for any folks that need to leave, please just know that you're free to do so. And my apologies for the time going longer than an hour. And for those that can stay, we really invite you to stay. We will be making the slide deck available, so just so everyone is aware of that. So continuing with our story of care. Next time we see Monica, she shares that the advice on strategies for reducing nausea made a difference, and she also has been drinking a tea prepared by her auntie. So I think that this is a great opportunity to really just do a nice check-in around her spiritual and emotional health. And so you might want to think about how you would do that in a chat, or how you already do that when you work with pregnant families. So some questions that come to mind for me is, how are you taking care of your spirit? How are you feeling about life balance? And I'm also curious, like, what are some, will she share, what are some teachings in her family around pregnancy, about being a life giver? Has she had a chance to connect around that? And is she interested in connecting with community cultural programming? So that really, as a care provider, means I need to know what's available and to be able to connect those that are interested in making that connection. And I think it's also that opportunity to share with her what I know about, you guys hear me? About culture, and like what we've shared today, that we know connection to culture in the ways that feel at her pace are actually strengthening her health, her family's health, and her baby's health. So I think that's a really important point to guide us as we move forward. And click again.
So Monica is 7 months, and her partner Sam is no longer taking any work where he has to leave the community. He's still drinking and smoking weed, and she lets us know that she wishes that he would stop. So we could tell her, you sound worried. How does that make you feel? And then she can let us know how she's feeling about it. And then also ask, do you want to chat more about it? Is now a good time? And I think one of our things is we want to see if she feels safe. Is she safe? What does she do for self-care and stress relief? Because this can be really stressful. Does she have a support system? Am I her only support? Is she coming to me with this because I'm the only person she trusts to talk about this? Can we connect her with other moms who may be in similar situations? You know, is there a group for Monica to attend? Would Sam be open to joining Monica in her appointments? You know, inviting Sam into our program with her? And are there support groups for Sam? Any parenting or dad groups for Sam that he can access? And what does a healthy relationship look like? Asking Monica if she knows what makes a healthy relationship, and then go through that with her. Next slide, please.
Yeah, and so then we, at the place where the couple is looking for support to when they travel to the hospital where they give birth. This is common in many rural and remote communities, that people have to go away from home to deliver or to have their babies. And so I think it's a real strength that this family has reached out looking for that support. So this may be an opportunity to connect them with doulas. If not in your community, perhaps there's a doula at the hospital or the facility that the family is planning to go to. Can we connect them? It's a reminder of the Doulas for Aboriginal Families programs, which is available through the Friendship Center. So please have a look into that if you're not aware of that. And if those options aren't available, what is there? Who can be there to support the family? And how can we also help them learn about the unit before we go? Many facilities now will have virtual tours, and we can talk through those pieces so that the experience of being in hospital doesn't quite feel so strange. And
so Monica and her partner Sam are proud parents of baby George Jr., named after Sam's grandfather. He was 8 pounds 1 ounce at birth and breastfeeding happily. So we want to know a few things next time they access our services. So first and foremost, we want to know how the birth experience went for the family. And this is for everyone involved. And keeping in mind that it might have been a great experience and it might not have been so great. So being prepared to support in those situations. Asking, is now a good time to sit and listen? And if it is, just sit and listen. Now is a good time to just sit back and take it in, and probably not share personal experiences or go on and on about situations that happened in your life. So sit and listen to the family. And also not share opinions. So what was surprising for Sam and Monica? What is challenging for them at this time that we can support them with? We could also ask about George Jr.'s name. And then also, what has Sam and Monica learned about their baby so far? You can thank them for sharing this personal experience with you, and let them know that you're truly here to support them. Thanks.
Click again.
Click again? Yep, thanks.
So at the 2-month vaccine, Monica and Sam ask about smoking occasionally, and they want your advice on how to do this safely. So maybe folks have come up against this. I know I have, and when I'm again with gentle curiosity, I really want to understand what is smoking, what does that look like to them? What are we talking about? Smoking cannabis, smoking. So what's that? And also the word safely, I think unpacking that a little bit. And so in a situation where they are wanting to use cannabis, maybe sometimes this is they're at a place where that feels like they want to move forward with that. It might be worth unpacking a little bit about what needs are being met by smoking cannabis. Like, is this because they want to have is it feeling like having fun or having time together? And are there other ways to do that? So we can maybe explore that a little bit. It's also a really great opportunity for some harm reduction messages. So what are they doing? I think we have a lot of gratefulness for the fact that they feel safe enough to share, but also become really curious about the things they already are thinking about, and what are they doing, and what are they worried about. So in terms of some practical ideas, we can suggest that they smoke outside, have a smoking jacket to reduce residue on their clothes when they come in, wash their hands, making a plan for responsive parenting. They're breastfeeding families, so breastfeeding first and avoiding the breastfeeding at peak time. So it takes about 4 hours for one person who only uses occasionally for there to significantly subside. But the peak is at the 1 hour mark. So breastfeed first and then maybe go outside. And just really remembering to ask permission to share the pieces I know and be driven by what their goals are. Anything I missed, Jody?
Nope, I think you captured it all. Thank you.
So yeah, next slide. These are some questions that I have found really useful for working with families. And sometimes when in a conversation like this, where someone asks me about safe use, that's such a loaded word. I think that everything comes with some risk, and so it is about managing those risks. And so when a family asks me something like that, I might read out some of these questions and suggest that they take them away and think about them. And so they're just ways of people sort of thinking through what is it that they might be considering cannabis for, and then thinking in a sort of a safe space, their own space, about what harm reduction strategies that they have already tried, so that when we come back together, we have something to talk about and to build off of that feels centered around their goals. So next slide, please. So now we're just moving into some other situations that have come up in our organization that people have shared that we were going to address in just a small way. That was a case that took us from prenatal to postnatal. Thank you for your patience with us in that. And so in these situations, we're talking we're just going to go through some examples of case stories that have come up for folks. You want to go ahead, Jody?
You betcha. So Cheyenne is a second-time mom and finds that cannabis relieves her pain. So she's sharing that she's using cannabis for pain. Can we talk this out with her? So is now a good time for Cheyenne? So what kind of pain? Some questions that we might want to ask her is, what kind of pain is Cheyenne experiencing? How often? What has she tried already to relieve her symptoms? Is there any harm reduction options? Is she open to discussing harm reduction at this time? And some of those harm reduction options might be, does she have a reliable source to access cannabis? Is she safely smoking? Is she using a pipe instead of rollies to reduce the chemicals? Different things like that we can ask her. Is she comfortable talking about this with her healthcare provider? So has she been to the doctor to see if there's any methods to help reduce this pain as well? Has she tried any traditional healing? That's an important question. How long has she had the pain, and what may have caused it? Was she in a car accident a while ago, and that's why she's in pain? And then also letting Cheyenne know that she was heard, and that it must be really challenging living and dealing with pain every day, and that we're here to support her. Next slide, please.
So we have Nancy, who had her first 2 children apprehended at birth, and they're now back in her care. And she shares with us that she used to use crystal meth and finds cannabis helps her maintain her recovery. So in this situation, I really just raise my hands to Nancy, who has shown a lot of strength and perseverance in getting her children back. And in sharing this with me, I really, want to know, what is her biggest concern? What matters to her most? And I'm going to have to explore some of my assumptions, but when I hear this, I imagine that she's feeling worried about being judged for her cannabis use, and also, you know, a tool that's worked for her so well in her recovery around her crystal meth use that, you know, how is that going to play out, and is she going to have a punitive situation that go along with that? So I think that really being her advocate, what does she do already to help her cope? Does she have connection with her culture that feels supportive? Is she feeling like she wants to make any changes? And if not, how do I support? How do I remain her witness and her advocate? And how do we identify the ways that she's doing safe and responsive caretaking? I think we just wanted to ask the group if there's any comments or if they have any other cases, but I am recognizing we're going over time, so we'll move along. These are some very good resources. First Nations Health Authority has the website there on breastfeeding cannabis, pregnancy and cannabis, as well as Perinatal Service BC has a wonderful pregnancy and lactation resource to consider. The next slide. We also want folks to be aware of the First Nations Virtual Substance Use and Psychiatry Service, which is available during business hours during the week. This isn't a service that families directly can call in. So if you're working in community with someone, you can make that referral, and that will help someone access to someone with substance use expertise. Next slide. And another really great resource, like in one of our cases, was around nausea and vomiting and pain and pregnancy. So another place for really good support around getting care is the Mabel line. So this is for folks in First Nations communities, and they can call directly themselves 24/7 or access via Zoom. So really great resources available. Next slide. And so in summary, connection really is the basis for growth and change. So we really want to invite everyone to remember that those relationships that you build are really, really important, as well as really reminding the things that people are already doing, their connection to their culture, spiritual strength, taking a family approach, really thinking about and making community connection, as well as thinking through as service provider how we provide safer relationships for people. Make a difference for your patients. So I don't know if Lucy's on the call still. I think she had to go, but and it was great to close us.
I'm still here. Are you finished now?
Yeah.
Okay. Hi, everyone. Thank you so much for staying on. Thank you for joining us today and participating, learning and sharing together. Take away the learnings that you have and that you can use in your practice or your own personal self or your family. So asking the Creator to cover your hearts and your minds and your spirit so that you're safe, your family is safe. Thanking the Creator for all the nutrition that was provided you today to nurture your mind, body, and spirit. And asking you to enjoy the rest of the day. And again, thank you for joining us. Be safe, everyone.
Everyone.
Take care, everyone.
Thank you, everyone.